My name is Dr. Wambugu. I'm very happy to be the last speaker of the day. We've had a long day today, and we hope it ends well too. These are interesting times. This poster you see down there is the one we had in the Afran Congress last year when we were inviting you to join us for Crack On this year. And you can see we had all the best laid plans to have it in Mombasa, as always, in September. But then, as you all know, life happened and put our plans, made our plans void. So today I've been given the task of taking you through lupus nephritis and looking at various aspects of management. It's impossible to go through the whole of lupus, as you all know, but I've chosen to take one or two things that may be useful in our discussion. I have nothing to declare. This usually means that the words I speak are not colored by any expected gain. So I will be broke as I am now after this talk. This will be the outline of my talk, small introduction, and then we'll go through the rest of the outline as captured there. I think we all know what lupus is. It's an autoimmune condition, cause not really known, but there are a lot of multifactorial things that come into play in how it manifests, be they genetic or hormonal, of course immunologic and environmental. That is why you have preponderance in certain gender, which is a female, and certain races have a more aggressive disease than others. Lupus affects any part of the body, many parts of the body. It's really, truly a multisystemic condition. However, the kidneys are affected more than 50% of the time. And really, in terms of severity, lupus nephritis is one of the most severe forms of clinical SLE. But whereas the rest of this talk will concentrate on lupus nephritis, it's important to know that lupus is associated with other forms of kidney disease, including thrombotic microangiopathy, antiphospholipid syndrome. And this can occur together with lupus or together with the immune complex, classical lupus nephritis, or on their own. And you can also have lupus podocytopathy, which of course, for you to diagnose that, you would need access to electron microscopy. And that is usually devoid of a lot of these immune complexes that are characteristic of the normal lupus nephritis. Okay, so for a long time, when you get to lupus nephritis, the biggest risk, of course, is progression of the disease, pushing you into end-stage kidney disease and forcing you into dialysis and all that. So the whole thrust of this talk is about trying to avert or delay or avoid this outcome. And the only way to do that is by having some immunosuppressive strategies to help you get there. But there's also a lot of work trying to look at new indicators that help the clinician determine when to be how aggressive, because this immunosuppression is not without complications. So you must balance the impact of your immunosuppression in delaying or averting progression of kidney disease with the expected side effects of the immunosuppression, which may be both infective or malignant in nature. So diagnosis, as always, carries from your history, your clinical cues, and now to the investigations. Urinalysis is always the easiest and the cheapest and the most available test that gives you a clue that your SLE patient might also have renal involvement. Then, of course, you'd want to do your kidney function tests, the various autoimmune markers. Complement levels are important, even in monitoring the care of your patients. But by and large, I'm seeing my internet is a bit unstable, so let me stop my video so that the presentation does not get too delayed. By and large, the kidney biopsy remains the best thing to help in knowing whether you have lupus nephritis, and more so what stage of lupus nephritis you're in. So when you have a lupus patient, when do you decide to do a biopsy? Basically, there's been a lot of back and forth about this, but by and large, I think the consensus is in that any lupus patient with any sign of renal involvement should be biopsied. This is basically because many a time the clinical manifestations are not always perfectly correlating with the pathologic findings on biopsy. So things like proteinuria, things like hematuria, things like a diminished GFR, don't hesitate. As long as there are no clear contraindications, go ahead and biopsy. A small tutorial on the glomerulus. We're not talking about pathology here, but it's always important for everyone to be on the same page. So this red line here represents the basement membrane, epithelial cells of the glomerulus. They are called podocytes, and they're usually arranged as food processes. The fenestrated cells on this other side is the endothelial layer. So a lot of glomerular pathology is defined using these terms, whether you're talking, and then this is the mesangium. The glomerulus, usually the membrane goes around the particular tuft, and it's surrounded by the podocytes, and there are mesangial cells in there, there are capillaries, and pathology rotates around that area. So this is just basically a guide to interpreting what these various classes are. We won't go through that since this is not really a class. But in 2003, the Renal Pathology Society and the ISN came up with a classification that most of us are familiar with, that classifies lupus nephritis from 1 all the way to 6, which is minimal mesangial all the way to sclerotic disease. But the aggressive lesions really that are associated with progression of kidney dysfunction are 3, 4, and 5. Can be focal, diffuse, proliferative, as well as the membranous GN. If you look at this, it's very glomerulocentric. Yeah, and you know, glomerular is not the only thing that the kidney has. So there was no representation on anything about chronicity or activity, which is important, because if your histology shows active disease, then it means you are likely to have a more aggressive disease, and if you do nothing, then you might get progression. It also ignores the tubules and the interstitium, you know, the famous IFTA, you know, interstitial fibrosis, tubular atrophy, which I think everyone agrees are the hallmarks of a very sick kidney. If your kidney has significant IFTA, then your prognosis is quite guarded. It also didn't talk about podocytes and thrombotic lesions and blood vessels. So based on this, in 2018, there has been a revision of this classification, and you can find this in this very interesting article in the Kidney International, and I've put it down for you to look up at your own time. And these are some of the things they've included in that classification, including crescents, which were not really previously captured well in the initial 2 or 3 classification. Now let's go to management, which is really the thrust of this talk. And every time you approach this question, I always like to ask, and it's always good practice to ask yourself what you want to achieve by your intervention. And this cuts across all areas of medicine, from nephrology to oncology to cardiology. You must set the goal of treatment at the beginning so that you don't miss it in the middle. So various trials have been done, and what has been uniform is that thus far, what correctly predicts better outcomes is the level of proteinuria that you achieve after your management. So the focus of management remains to try and suppress the level of proteinuria, ideally to less than 0.5 grams in 24 hours. That's within the first year of treatment. But you'll realize that this is not, whereas guidelines are nice and give you specific timelines, patients rarely follow books, as they say. So really, you must look at these expectations with some, you must color them with some element of reality. So that if someone had a nephrotic range proteinuria at the beginning, then you may not expect that level of proteinuria to go to this target in the beginning, within 3 to 6 months. And you may be allowed some latitude. That's why they talk about the first year rather than just the first 3 to 6 months. So as long as there's a significant reduction in proteinuria, then you should be happy. So partial or complete remission is an acceptable goal of therapy in lupus nephritis, and that is the same presented in a simpler way. Of course, if you fail to achieve even a partial remission within your first year of therapy, then you are dealing with probably refractory disease, and we'll come to that at a subsequent stage of this talk. Now, nephrology has come a long way, and we try as much as possible to practice our science based on evidence. Sometimes not everything has been studied, that's not possible. But a lot of studies have been done, and where there are no studies, then practitioners of nephrology usually come together and discuss various aspects of it and try and come up with guidelines that make sense for everybody. So the initial guideline, and lupus nephritis is one of the glomerulonephritides, and so GNs are usually cohorted in the same guidelines. So there's this organization which I think everyone knows about, and if you don't, please take a note of it: Kidney Disease Improving Global Outcomes, KDIGO. It was initially embedded within ISN, the International Society of Nephrology, but now they are on their own. And really, their thrust, the gist of why they exist, is to come up with guidelines to guide standardization of therapy in people with kidney diseases. So 5 years after the initial the GN guideline that they had launched, they sponsored what they usually call controversy conferences on GNs in Singapore. And they had this conference in 2017, and they came up with a document in 2018, which we will reference widely in this talk. This is just to tell you that KDIGO is not an amorphous body, it's made of human beings, and they try as much as possible to involve as many people as they can from various parts of the world. So there is the North Americans, Canada, USA, you have Hong Kong there, you have New Zealand, you have Denmark, you have Italy, okay? And they discuss things, they break out into breakaway rooms and talk about various aspects of whatever it is they're discussing. I put this slide just to show you that two things. One, we are not enough Black people represented. So we need to pull up our socks and do more research and interpret our results. And of course, to jealously remind you of the good old times when we could all gather together in such close proximity without the phobia that now envelops every gathering that we have, that is even now forcing us to meet remotely. That's how KDIGO puts their recommendations. They either suggest or recommend, and their gradings of the same depending on the quality of the evidence. So the first thing we must agree is that everyone with lupus nephritis must be on hydroxychloroquine. Of that, there is no conflict, there's no argument. That one is a hard fact. The only caution that you are reminded of is to look out for ocular toxicities. These are real, and whereas in the first 10 years you might have less than 2% of those complications, in 20 years of being on hydroxychloroquine, the ophthalmic complications go even towards 10%. So this is something many of us forget to do. So a lupus patient in your care must have, as part of his regular routine, a regularly scheduled annual ophthalmologic assessment. I say annual because that's more practical for us instead of trying to count the first 5 years on treatment. Remember, it is excreted renally, and therefore you must remember to dose adjust. The ophthalmologist advised that as long as your dose does not exceed 5 milligrams per kg, then you are more or less safe in terms of retinal complications. So we will concentrate mostly on the immunosuppressive aspects of management of lupus. So when you're talking about class 1 and class 2, that is really minimal mesangial or mesangial-proliferative, unless there are extrarenal indications for immunosuppression, then really just supportive management suffices. Okay. But when you're talking about class 4 and class 3, which is the proliferative, as well as class 5, then some form of immunosuppression is warranted, because now this is a rapidly progressive condition and may need intervention before it progresses to stage 6, which now means you are nearing renal failure. Management is for the 3 and 4, which are the prototypical proliferative types, is divided into induction therapy, which is what is being called here as initial therapy, and maintenance therapy. And there are various approaches to the induction therapy and maintenance therapy, which we'll come to soon. This in class 5, which is membranous, if you have a purely membranous nephropathy, then you should only initiate immunosuppression other than the hydroxychloroquine, which is, we've agreed, is universal, where you have overt nephrotic syndrome. And that one, then you can initiate with the mycophenolic acid analogs as well as cyclophosphamide. You choose what you want to do. Now let's go first to stage 3 and 4. And there have been a lot of trials in this regard. And currently, what is recommended is the Urolupus regime of cyclophosphamide. This basically involves using lower doses of cyclophosphamide. Let's do it this way. So when you have your biopsy, and you remember I told you the classification have changed, so there is an element of activity now in the classification. So when you have 3 or 4 active disease, then everyone gets steroids. That is one. So you start with a 3-day duration of methylprednisolone, then you migrate yourself to orals, and then you taper the same over the months. Now, this first IV cyclophosphamide regime is what is called as the NIH regime. It's very aggressive, and it was the initial one that was used. But of course, with higher levels of cyclophosphamide, so do the complications follow, including things like secondary infertility. And remember, the prototypical lupus patient is a young lady in the prime of her life and very much desiring children. So you must take that into consideration. You treat the patient as a whole. You don't just attack the disease and ignore what they need in their life. You can also use oral cyclophosphamide, but number 3 here is what we are calling the Urolupus regime. You use a smaller dose of the cyclophosphamide at shorter intervals, but 6 doses of the same. You can also use mycophenolic acid analogs, but I want everyone to note the doses that you use for induction of remission. Many of us sometimes using suboptimal doses. We rarely go beyond 2 grams in a day of the MMF for 14 a day of the mycophenolate sodium. But it is recommended you go aggressively. Remember, your induction is just for about 6 months. And thereafter, when it comes to maintenance, now you can scale down on the dose a little bit. For those patients who, and many of us will prefer to start with this because we are trying to spare our patients the toxicity of the cyclophosphamide. But there are many of our patients who are totally unable to tolerate the doses of 3 grams, for example, because of maybe say GI side effects. So at that time, then you're allowed, and there is evidence for multi-targeted therapy, in which case you add a calcineurin inhibitor to the steroid, and then to the maximum tolerable dose of your mycophenolic acid analog. So this is the same represented in a clearer way. So this is induction, as we've talked about. But then after induction, and we hope that your induction achieves at least partial response, then you go to maintenance, because you want to make sure that there is no flare. Maintenance usually is with steroids at a dose of 10 and below, because remember, you're also trying to minimize the cumulative side effects of these drugs. Then at that time, MMF is still the preferred option for maintenance, followed by ASA. And then, of course, if for some reason, one reason or the other, these two are not an option, then you can use other things like CNIs. And the doses are usually a bit more modest than the ones you use for induction. So there are some trials that showed the relative efficacy of MMF versus ASA, and whereas some show equivalence in terms of flare rates and progression rates, most prefer MMF as a preferred maintenance immunosuppressive regimen. But remember, you're managing patients, so you must work in a reality. If your patient is unable to afford the mycophenolic acid analogs, there is nothing wrong with putting them on azathioprine. There is this drug here, CNIs. We said if either of them are not an option, you can have CNIs or mesoribin. Mesoribin, I know some of them will ask, so I've given you a reference to check what this is. Many of us have not interacted with this drug, but it's mostly used in Japan and is said to have good effects in lupus nephritis as well. Okay, so that's basically the maintenance regime on the same. So how long do you maintain these people on treatment? Are you going to put them on these drugs forever? Now, this is really the question, because most flares will happen in 5 or 6 years. So most people should be on treatment for at least, most people agree that 3 years is a good place to maintain your maintenance therapy at. But then what guides you? What makes you feel brave enough to say, okay, now I think you're okay and we can stop? So now this is where we are now as a nephrology community, trying to figure out whether there are any scientific ways of deciding how to withdraw immunosuppression. And there have been a lot of studies ongoing on this. I just took 1 or 2 examples. Malva, for example, decided to do protocol biopsies on all patients who had been treated and were in remission for at least 1 year. And I think we already defined what remission was. And even on those people who, remember, the recruitment was you're in remission clinically for 1 year. So even those who were thought to be in remission, you could see that out of 76 people, 21 of them actually had active disease present. That's just putting into the picture the importance of biopsy guiding every decision you make when it comes to lupus, because one assumes if immunosuppression had been stopped in this group, then the flares would have really gone up. So in this group, of course, when there was activity, immunosuppression was continued for another 2 years, and the same subsequently. So, but look at the endpoint. These people were followed for almost 8 years. And in all those 8 years, there was only a 9.2% flare. And those must have been caught and treated because they were actively sought. CKD was 16%, but there was no one who pushed on to end stage and no one died, which is the whole idea of management of lupus. So now talking about goals of therapy and when to do a biopsy. What pushes you to do a biopsy? You've had a patient, you've diagnosed him, you've initiated management, you've done induction, you've done maintenance. So a couple of things can happen. Everything can be perfect. You can get a complete clinical response that is sustained. And then now you start thinking like the previous guy, do we stop? And at this point, there might be an argument to be made to do a biopsy just to confirm histologic remission so that you're brave enough to stop. Or you can get a flare, a remission that then flares, and then now it depends now. If your initial biopsy was already the 3, 4, 5s, then you may not need to re-biopsy because really you won't find anything worse than that. So you just treat again. But if the biopsy was quiescent initially, and you find that everything is going haywire, then, and especially with 4, 5, you may need to re-biopsy because you might have now developed into a 3, 4 lesion that now needs more aggressive management. Partial clinical response, many of the patients are like this. This again, there are pros and cons, the arguments for and against, but the only argument against here is that you might do a biopsy and you might see no activity, therefore you might spare the patient the side effects of continued immunosuppression. And the same for worsening kidney function that may just show scarring, which no immunosuppression can reverse, obviously. Right? So there are a lot of discussions around when to biopsy and when not to biopsy. In the clinic setting, because not many patients will allow you to biopsy them when they're doing okay, you can do a lot of these tests to help you predict or suspect a flare. You know, urinalysis now coming, hematuria that had previously disappeared coming back, casts, C3, C4 levels going down, C1q antibodies, which usually have the higher correlation with activity compared to other things like anti-DS DNA titers. So let me remind you about what response is. And now I want us to talk about refractory disease, where there is no partial or complete response. And when you find these people, then obviously, like all of us know, adherence, you have to find out first whether your medication is being taken. But if it is confirmed that it is being taken and this is a true refractory management, you might need to repeat the biopsy as we've discussed previously. You might be dealing with something else like a TMA. Then if you started with one agent, you should maybe consider switching to another agent. So if you were on cyclophosphamide initially, maybe try MMF and vice versa. Then you can now do add-on therapy with more aggressive things like the rituximabs. You can consider increasing the duration of your cyclophosphamide, which is a very potent immunosuppressant. You can consider IVIG plasmapheresis, although the evidence for this is not as robust as one would want. But as you realize, when you are dealing with refractory disease, your options are rather limited. Okay, fine. So that's basically that. So there are various beta cell depleting therapies. Rituximab is there. Obinutuzumab is there. And belimumab as well. And although many of these monoclonal antibodies are being tested in the background of standard of care. So the jury is out on many of them. There is also new CNIs being brought on board, including voclosporin. There was a nice paper on a study called Aurora, which I encourage everyone to look into and see. So it's basically a modified cyclosporin that has less of the side effects and promises perhaps to have to remove the need for therapeutic drug monitoring. But again, these are early studies. We await the verdict. And of course, there are those who have gone all the way in refractory disease to even do autologous hematopoietic stem cell transplants. This is a study from China. Now, relapse is a bit easier. Relapse means you treated him, he got better, and now he's sick again. So basically, the advice is you do what you did the first time, and maybe don't withdraw your maintenance too early the second time around. So some special circumstances which you should mention: pregnancy, antiphospholipid syndrome, and kidney failure. So basically, antiphospholipid will most likely come in with a thrombotic microangiopathic picture. And for all of this, there are various interventions, which all of them are quite expensive to our patients. You're talking plasma exchange, you're talking complement management, complement inhibitors, eculizumab. So biopsies and doing all this lab support is very important in guiding your treatment going forward. There's a lot to be said about pregnancy, so we will not belabor it. Many of you who log into the KAP talks would have remembered that there was a talk on this for a whole hour. So I'd recommend you go there and have a look at that. However, the things to remember about lupus and pregnancy is that you should advise your patients to defer this getting pregnant until the disease is no longer active. Remembering, of course, that as the drugs you're using to try and get the disease in control, many of them, at least the more potent ones, are teratogenic. So it's not a good idea for her to get pregnant. But if the decision has been made and the patient is already pregnant, then the last bullet here tells you the drugs that are safe in pregnancy. Of course, don't forget hydroxychloroquine must always remain on board, as well as probably aspirin if pregnancy ensues. For the patient who has lupus and kidney failure, remember transplantation is still preferred. They do better on transplantation than they do on dialysis. And you don't have to linger and wait for activity levels to be zero to transplant. Just go ahead, transplant, because even if they get a flare in the graft kidney of lupus nephritis, it rarely results in graft failure. But dialysis in someone who is immunosuppressed will carry with it a lot of morbidities, including cardiovascular mortality. Now, I thought probably as we come to the end, to mention one or two things about the challenges in lupus nephritis. We've talked about the issue of knowing when to stop the maintenance treatment. And there are a lot of research going into what is the best way of making these decisions. Is there a marker that we can use that removes the need for biopsy? Is there a surrogate marker that is accurate enough to guide us? So there's this very nice article in JASN, which I've referenced there for you, that looked at something called the urinary soluble CD163. And it was a very elegant design. They took people with active lupus. Not everyone had renal involvement. And they also took people with GNs that were non-lupus to try and figure out what to make of this marker. And what they found is that when they did a biopsy and do the marker, the levels correlated very much with histologic activity. More so, the levels varied with treatment, so that when there was a flare, then the levels were up. When someone responded, the levels came down, and the non-responders, the levels were more or less static. Okay. Then when you compared the histology on repeat biopsy to the levels, you found that they did a better correlation with the CD163, or there was a better correlation with them compared to proteinuria. So it looks more or less quite perfect, isn't it? And they're saying it's something to be looked into because it might be valuable in as a very nice lupus nephritis. Lupus nephritis, I'll explain why I'm saying lupus and not just GN. Because when they compared the levels of this in patients with lupus and those with other glomerulus diseases, you can see that only the people with lupus, with active lupus nephritis, had significantly high levels of the urinary CD163. Membranous FSGS, IgA nephropathy, they were non-impressive. Then, as always, the levels tended to go up with severity of disease, which is also important. And you can see it's a significant finding. And as we said, with responses, so that people who had a complete response showed a lower level than those who had no response, which showed persistently high level. So these are very interesting things to look at. But I don't want you going out there and saying it's the only thing that's being studied. There are very many that are being studied. In 2018, CD11B was also studied and was shown to be useful in estimating the histopathologic activity in lupus nephritis. So that brings us towards the end and some take-home messages. So remember, the classification has changed in 2018 and to include the tubulointerstitial, vascular, and podocytopathies. Remember, repeat renal biopsies have a role and can guide you in a big way in choosing when to withdraw your immunosuppression. There's a lot of work looking at predictors of long-term clinical outcomes. Proteinuria has been the thing we rely on most because of its availability and the fact that it's cheap. But remember, like I've told you, a lot of newer biomarkers are being studied and are coming on board, so that the holy grail would be having a surrogate that can tell us what is going on histologically in that kidney without having to do the invasive kidney biopsies. In terms of medication, remember hydroxychloroquine is for everybody. Don't forget about the retinopathy. Always try and minimize the doses of your steroids to prevent the side effects of the same. Cyclophosphamide MMF regimens remain the gold standard for induction of remission. Calcineurin inhibitors are also coming on board. I talked about proclosporin. And the maintenance therapy, again, a question in everyone's mind. How long do I keep my patient on maintenance immunosuppression? And the role for biopsy even in this situation. Asanteni sana.
As somebody is thinking, maybe Dr. Wambugu can clarify for us after successful remission and passing those 3-4 years of maintenance therapy. When you withdraw immunosuppression, what happens to the hydroxychloroquine?
It stays. I think hydroxychloroquine must always be on board. I don't think there's anyone will be brave enough to keep it, to withdraw it completely. At least that's the practice most of us have, including the rheumatologists who many of us work with. Other than the ophthalmologic complications, I don't think there is much to worry about the more severe side effects of immunosuppression that we encounter with the other drugs. I don't know what your practice is with HCQ.
I have a question from Laura Curry about CD163, the soluble one. How does it perform in populations with HIV prevalence? Does this increase
does this increase detection and sepsis as well? Will that affect its ability to detect lupus nephritis? I'm afraid I don't know enough about CD163 in the HIV population. But with the comparisons they did with the other GNs, it seems to be quite specifically bending towards lupus nephritis. But I must say I don't know enough about it in the HIV context.
Okay.
Which is the most important monoclonal that you would like to incorporate in your practice for the novel therapies? No,
so rituximab is important, especially for class 5, but because I'm sure all of you know that even in membranous nephropathy, primary membranous, that is it's looking like it might even be accepted practice to have it as a first line because of the lower relapse rates that we are having with it. So for now, rituximab must be in the back pocket of every nephrologist. Don't be shy to use it. It's available in the country. There are even some generics, and you should not let your kidney go when you have refractory disease without giving it a chance.
Dr. Wambugu, now I've gotten a challenge of management of a young lady with lupus nephritis. And usually you would want to reverse to an activity stage, but then you try to avoid cyclophosphamide because of the obvious side effects of infertility. Now, what do you do? Because that's the greatest challenge I found, because the question the young woman would ask you, you have gone through, you've even used, may start with all the prednisone, you have done pulse therapy, you have been on various regimens of prednisone, you have brought in MMF, you have even brought in cyclophosphamide. Before you bring in cyclophosphamide, you have gone even with azathioprine, you have brought in cyclosporine. Now, just before you, as you know, you'd want to go into cyclophosphamide. Have you found a scenario where the patient will ask you, will I get pregnant again after this? And then what would you do? Because I think most of the time you may go into cyclophosphamide and you might not succeed, and then now you go to where the next level of the rituximab you are talking about. Have you gotten a challenge of such a patient of infertility from cyclophosphamide and a young woman, alliparous woman who want to get a child, but you cannot be able to control the activity of the lupus nephritis?
Of course, I think all of us have such patients. You remember, most of these patients are young, reproductive age, want families, very impatient to do so. But they also appreciate the fact that getting pregnant in active disease will cause progression of their disease. And I assure you that the risk of going into kidney failure sometimes works as a deterrent, and it makes them listen to you. But as you said, once you have this patient, you said you have been on MMF, you said you've been on AZA, you've been on cyclosporine. This is where the reason I spent so much time trying to convince us that the first biopsy is not enough is exactly for this particular scenario. So that you must define what you're dealing with now, doc. Is this still active disease, or have you lost that kidney? Is it gone? Is it fibrosed? Is it a class 6? In which case, it doesn't matter what you throw at this lady. You might just be piling on side effects as you correctly put them. Should you be planning for a preemptive transplant, for example? So these patients exist. In fact, they don't just exist in the lupus world, they exist in the transplant world. And there is many a time when a patient who has just crossed over the 1 year mark of transplantation now comes and stares you in the face and tells you, okay, now I'm going to get pregnant, so you must now transition me to pregnancy safe drugs, even if, of course, you as a nephrologist have a primary concern of that kidney. But life must continue. We do what we do so that people can live full, holistic lives. So when you have such patients, and even that patient who you're now considering giving them giant doses of cyclophosphamide and who are worried about their future fertility, then you must now introduce them to the gynecologists. Gynecology has come a long, long way, and they even go ahead and freeze their eggs. And after you've controlled your disease or reached some sort of resolution on that, then IVF can now happen. And there's nothing wrong with the uterus of this lady. It was just her ovarian function that would have been affected by the giant doses of the alkylating agents that you gave her.